So the remainder of the morning section is going to be encompassed by kind of a joint lecture between two specialties that merge more closely together over time. Dr. Henry Huang is going to speak on cardiovascular update in reference to medications, lipidology, and Dr. Ichiro Nakai will then take on the task of dovetailing that with the treatment of diabetes. And hopefully the two concepts will merge together and pass along a great deal of information. A disclaimer, neither one of them are robots. And Henry comes to us by way of his undergraduate training at the Massachusetts Institute of Technology and then Columbia Medical School. And then he did his internship and residency at Scripps and fellowship in cardiology at CPMC in San Francisco. He also worked for a few years in the Kaiser system and then became an academic at the University of Southern California School of Medicine and then subsequently, very gratefully, has joined our practice. Ichiro Nakai, has been a diabetologist and endocrinologist here in Sonoma County for a good long period of time and has really been the stalwart behind elevating the treatment of diabetes, both medically and from the concept of a diseased management for a long period of time. So I first will introduce Henry Huang, and then he will be followed by Dr. Nakai with the second part of the lecture. Henry?
Well, thank you, Tom, for the very kind introduction. It's an honor for me to be invited to speak at this symposium today. And my talk today is going to be on lipids and novel therapies for lipid lowering. And here's the outline of my talk. First, I want to go over some basic concepts about lipids and cardiovascular risk, and then we'll move on to cardiovascular risk assessment in the individual patient. I then want to focus on a particular high-risk patient, the patient with familial hypercholesterolemia, because a lot of research that's been done into this condition has led to the development of lipid-lowering therapy, not just for familial hypercholesterolemia patients, but for many other patients who need and benefit from LDL cholesterol lowering. And then I'll go over some updates in pharmacotherapy before going over what I want you to take away from my talk. So without further ado, we know that there are different lipoprotein classes that are involved in cholesterol metabolism. The HDL, or good cholesterol lipoprotein particles, are involved in reverse cholesterol transport from the circulation from the arterial wall to the liver, and they are potentially anti-inflammatory and anti-atherogenic, whereas LDL cholesterol-containing lipoprotein particles are potentially pro-inflammatory and pro-atherogenic. And we know a lot about the role of lipoproteins in atherogenesis now. We know that high plasma levels of LDL lead to LDL infiltration into the intima of the arterial circulation, and that oxidative modification of LDL with macrophages and other inflammatory factors lead to the development of atherosclerotic plaque, and that further endothelial injury with platelet adherence and cytokines with inflammation lead to progression of atherosclerosis. And as I mentioned, HDL particles are involved in a reverse cholesterol transport pathway, facilitating cholesterol uptake into the liver and away from the arterial wall. So we understand a lot now about the molecular biology behind lipid metabolism. We've also accumulated a lot of epidemiologic data about lipids and cardiovascular risk. On this slide is some data from the InterHeart study that looked at attributable risk factors for first myocardial infarction. And as you can see, lipids comprise a predominant risk attributable for a first myocardial infarction. And we know that coronary heart disease risk increases as LDL cholesterol levels increase. Meta-analyses have also shown that an elevated triglyceride level is associated with increased coronary artery disease risk. And I think one of the questions that I'm going to explore in my talk and that Dr. Nakai will probably explore in his talk are whether drugs that address specific metabolic factors like lipids and diabetes actually reduce the risk of coronary artery disease. But how do we decide whether to start lipid-lowering pharmacotherapy or not? We start with an assessment of the patient's cardiovascular risk, because the higher risk patient is the one that will benefit from more aggressive lipid-lowering pharmacotherapy, while the lowest risk patients won't. And so many of you are familiar with the National Cholesterol Education Program Adult Treatment Panel guidelines for lipid lowering and cardiovascular risk assessment. These guidelines have been updated over the years and are based on a multitude of clinical trials and epidemiologic data. And these guidelines have spanned the course of time from the 1970s to the 21st century. And the most recent set of guidelines updated in 2004 advocated risk assessment by categorizing patients into low, intermediate, and high risk categories based on 10-year coronary heart disease risk. If a patient has 0 to 1 cardiac risk factors, then that patient tends to fall into a lower risk category with a 0 to 10% CHD risk over 10 years. Patients who have 2 or more cardiac risk factors fall into an intermediate risk category. And then patients who have coronary artery disease or risk equivalents are going to have a 20% or more risk of cardiac events over the ensuing 10 years. So in the NCEP algorithm for cardiac risk stratification, step 1 is to identify the highest risk patients first, those who have coronary heart disease or risk equivalents like diabetes, history of CVA or TIA, evidence of carotid or renal atherosclerosis, peripheral arterial disease, or an ankle brachial index of less than 0.9, AAA. And once you've identified once you've determined that the patient is not one of these high-risk patients, then you would classify the patient by counting the major coronary heart disease risk factors to come up with a point score. So the risk factors are listed on this slide. Age greater than or equal to 45 for men, greater than or equal to 55 for women. Hypertension or the need for blood pressure medicine, smoking, low HDL cholesterol level less than 40, and if a HDL cholesterol level is greater than or equal to 60, then you would subtract 1. And finally, a family history of premature coronary heart disease, defined as having a male first-degree relative developing CHD at less than 55 years of age, or a female first-degree relative developing CHD less than 65 years of age. And so, looking at these different risk factors and counting how many of them are present in a particular patient, you would come up with a score. And for those with 0 to 1 points in the score, you would assign that patient to a lower risk category. But for those who have 2 or more major risk factors, as defined on the previous slide, you would calculate the Framingham risk score to estimate their 10-year risk. And if their 10-year risk is more than 20%, then it's a coronary heart disease risk equivalent. And if not, then the patient would be assigned to a moderate risk category. The NCEP ATP3 guidelines would advocate for certain LDL cholesterol goals and cut points for drug therapy depending on which category an individual patient would fall into. Now, for patients who have very high triglyceride levels, greater than or equal to 500, the first priority of treatment is to lower their triglycerides in order to prevent acute pancreatitis. And trying to attain certain LDL goals for preventive purposes is secondary until you can get their triglyceride levels more normal. Now, many people have noted the limitations of the NCEP ATP3 risk stratification system. For one thing, the Framingham risk score can assign a low 10-year risk to some patients with a moderate to high lifetime risk who might benefit from more aggressive risk factor modification. So an example would be the younger patient who has a low 10-year risk but actually has a very high lifetime risk for coronary heart disease. Another limitation of Framingham that's been noted is that most of the patients enrolled in Framingham studies were men, and so the results may not necessarily be as applicable to women. And finally, Framingham doesn't include some risk factors that may have incremental predictive value, like family history and inflammatory markers. So the Reynolds risk score was developed to help address some of these concerns. It incorporates additional cardiac risk factors, HSCRP and family history. And so for those of you who want to use the Reynolds risk score calculator, you can actually go to reynoldsriskscore.org, and it's an online calculator that will allow you to put in not just some of the traditional cardiac risk factors, but HSCRP and family history information. And this risk score calculator has been validated in large clinical studies, including this one that was published in JAMA, showing that a large population of intermediate risk patients, both women and men, could be successfully reclassified as either higher risk or lower risk, depending on their Reynolds risk score. I mentioned HSCRP, which has been shown to be an independent marker of cardiovascular risk in the intermediate risk patient. It is a nonspecific inflammatory marker with greater than 40% individual variability. And so patients who are sick with an infection or inflammatory condition can have elevated HSCRP levels that have nothing to do with cardiac risk. And also because of significant intra-individual variation, you need to average at least 2 separate HSCRP measurements before you use it in any sort of risk calculating score. But HSCRP does aid in individual risk stratification for the intermediate risk patient and can direct further treatment. In terms of HSCRP results, low risk would be considered a value less than 1, average risk 1 to 3, high risk would be greater than 3. And so HSCRP is a tool that can be used to further classify and stratify the intermediate risk patients. Now, in 2013, the ACC-AHA published new guidelines for cardiovascular risk assessment and lipid lowering. These guidelines provided a more generalized and somewhat vague approach to risk assessment and lipid lowering. And there are guidelines that have some limitations, but I think they've also provided some value in thinking about the individual patient at risk. These guidelines identified 4 groups of patients who could potentially benefit from statins. The patients who have clinical atherosclerotic disease, or the secondary prevention patients, patients who have a familial or genetic dyslipidemia with an LDL cholesterol greater than or equal to 190, patients with diabetes, and patients who have an estimated 10-year coronary artery disease risk greater than or equal to 7.5%. And this risk was calculated using a new risk score calculator that was based on pooled cohort data. And the risk score calculator was criticized and is controversial because many people, many experts feel that it doesn't necessarily categorize patients all that accurately. But nonetheless, I think that where these guidelines had value was in identifying groups of patients that could potentially benefit from statin lipid lowering therapy. Again, these groups were those with clinical atherosclerotic disease, LDL greater than or equal to 190, diabetics, and patients with a 10-year risk of greater than or equal to 7.5%. And then the guidelines would have you further stratify by factors like age and the actual risk score calculated before deciding whether the patient should receive moderate intensities or high intensity statin therapy, as defined on this slide, where moderate intensity statin therapy would be statins and doses that lead to LDL lowering of 30 to 49%. So simvastatin 20 to 40 milligrams would be an example. Atorvastatin 10 to 20 milligrams would be an example. High intensity statin lowering therapy would be defined as atorvastatin 40 to 80 milligrams or rosuvastatin 20 to 40 milligrams. And these, these guidelines again were meant to help people think about patients who could benefit from statins and provided a somewhat simplified approach to the decision about whether to start statin therapy or not. Personally, I've not found the guidelines to be terribly relevant or helpful in my own practice. And I feel that there's a certain vagueness to these guidelines, and oftentimes patients and doctors want specific guidelines, and oftentimes patients and doctors want specific goals for therapy. But I certainly see mostly high-risk patients in my practice, and I think that these guidelines and the National Lipid Association have helped direct attention to some of the high-risk patients that maybe we weren't paying enough attention to. And I think one example of the very high-risk patient would be the patient with familial hypercholesterolemia. As I alluded to before, familial hypercholesterolemia is a genetic condition, and research into this condition has not only led to a better understanding of lipid metabolism, but has allowed us to devise lipid-lowering therapy that helps familial hyperlipidemia patients, and has also helped many other patients who are in need of lipid lowering. So what is familial hypercholesterolemia, or FH? It's a genetic condition that results from a codominant genetic mutation that affects the formation or function of the LDL receptor. This causes a metabolic defect characterized by increased LDL because of reduced LDL clearance. And the clinical phenotype of this condition is marked by premature coronary artery disease or peripheral vascular disease. Patients can develop aortic stenosis. And there are certain clinical signs that can go along with familial hypercholesterolemia, especially in the homozygous form. Tendon xanthomas, corneal arcus, and xanthelasmas. But none of these signs are highly sensitive for familial hypercholesterolemia. So why does familial hypercholesterolemia matter? It is a condition that has a prevalence that's estimated about 1 in 200 to 500 patients, meaning that more than 8 million patients are affected worldwide. There can be an up to 1 in 60 prevalence in local groups that have a genetic founder effect. And it's a condition that we're not necessarily doing a great job of detecting. There's definitely room for improvement in detecting these patients. These patients are often missed and misdiagnosed. The impact of familial hypercholesterolemia is significant. About 5 to 10% of coronary heart disease events under the age of 60 occur in these patients. Cardiovascular death occurs in greater than 80% of familial hyperlipidemia cases. And their absolute cardiac disease risk is much, much higher than that of the general population. This is an example of a patient who has homozygous familial hypercholesterolemia. And again, those with the homozygous condition have a much more severe phenotype than those with heterozygous familial hyperlipidemia. This is a 28-year-old patient. She began developing cutaneous xanthomas at age 3, as you can see on the left-hand panel. These cutaneous xanthomas are something that can be seen in patients with severe familial hyperlipidemia. She developed obstructive coronary disease and required CABG at age 12, and she had LDL cholesterol levels that were off the charts at 780. Here are some of the clinical characteristics that you can see in severe familial hyperlipidemia. On the left-hand side are examples of tendinous xanthomas. Patients can develop corneal arcus at a young age, less than 45 years. And one can also see xantholamas on the upper or lower eyelids. Homozygous familial hypercholesterolemia causes markedly elevated LDL cholesterol. These patients, again, typically develop cardiac disease at a very young age. They can also have joint symptoms such as tendinitis, arthralgias. They can have skin lesions like the xanthomas that were on the previous slide. And because it was recognized that these patients represented a very significant unmet medical need, there's been a lot of research done on the genetic basis for familial hyperlipidemia, and this research has led to a better understanding of the condition and has allowed us to devise therapies that can address hyperlipidemia. And again, it's turned out that these therapies can help not just these patients, but other patients who are in need of lipid lowering. The most common metabolic defect in familial hypercholesterolemia is represented here on this slide, where you have a defect in LDL receptor production. So there is absence of the LDL receptor on the cell surface of hepatocytes, and so the liver is no longer able to take up LDL particles from the circulation, and this leads to a higher LDL cholesterol level and more atherosclerosis. Another type of familial hyperlipidemia can occur if the patient has defective ApoB100. ApoB100 is a lipoprotein that is on the surface of a LDL lipoprotein particle. It helps facilitate binding of the LDL particle to the LDL receptor on the liver. So you can imagine if the ApoB100 is defective and the LDL particle is less able to bind to its LDL receptor, there's going to be more LDL in the circulation and more potential atherosclerosis. A third type of familial hypercholesterolemia requires us to discuss the LDL receptor function and life cycle a little bit more. Here on this slide is an illustration of LDL receptor function and life cycle, where you can see that after production of the LDL receptor, LDL receptors are expressed on the cell surface membrane and are able to take up LDL particles through endocytosis into clathrin-coated vesicles. And then the LDL is degraded in a lysosome, while the LDL receptor is recycled back to the cell surface membrane to take up more LDL particle. Now, as it turns out, there is a serine protease enzyme called PCSK9 that is involved in the regulation of LDL receptor expression. And specifically, what PCSK9 does is it targets LDL receptors for lysosomal degradation. So circulating PCSK9 will bind to the LDL receptor particle complex. And after this complex is endocytosed, those receptors that are bound to PCSK9 will not be recycled back to the cell membrane, but will be degraded in lysosomes along with the LDL. And so, understanding this biology has allowed researchers to devise therapy targeting PCSK9 as a way to lower circulating LDL cholesterol. As it turns out, this came about through the discovery that PCSK9 gain-of-function mutations can cause a form of familial hyperlipidemia. So if we go back to this slide, if you have a hyperactive PCSK9 that results in more LDL receptors being degraded in lysosomes, then there's less LDL receptor on the cell surface. And then a greater amount of LDL circulating in the bloodstream. And so, as I alluded to, researchers have been able to develop an anti-PCSK9 monoclonal antibody that can bind to PCSK9, interfere with its function, so that it no longer is able to target LDL receptors for degradation, so that more LDL receptor is recycled back to the cell membrane and less LDL receptor is degraded. So again, the mechanism of action of a PCSK9 inhibitor monoclonal antibody is to bind PCSK9, prevent degradation of LDL receptor, and by increasing the amount of LDL receptor that is expressed on the cell membrane, there's more clearance of LDL from the circulation. So you have lower LDL cholesterol levels. And as monotherapy, PCSK9 inhibitors can cause up to a 50 to 70% LDL reduction as, on their own. In 2018, the PCSK9 inhibitors that are available are Evolocumab, or Repatha, which is marketed by Amgen, and Alirocumab, or Praluent, which is marketed by Sanofi. These drugs are administered via subcutaneous injection every 2 weeks or 4 weeks, every 2 or 4 weeks. And because these monoclonal antibodies are cleared by the reticuloendothelial system, there's no dose adjustment that's required for patients with renal or hepatic failure. And these drugs have been shown to be fairly well tolerated. Side effects that can happen with these drugs can include injection site reactions, hypersensitivity or allergic reactions, or influenza-like symptoms, such as nasopharyngitis. But on the whole, these drugs have been fairly well tolerated in clinical trials. But as we've seen throughout medical history, it's one thing for a drug to be able to have a desired metabolic effect, like LDL lowering or glucose lowering. And it's another thing for the drug to actually improve cardiovascular outcomes or hard clinical endpoints. And I think that's where additional research has been done. And I think that's why the fourier clinical trial has importance, because this was a randomized double-blind clinical trial that showed improvement in cardiovascular outcomes, not just LDL lowering, but improvement in cardiovascular outcomes by adding Evolocumab to statin therapy in coronary artery disease patients. This was an important clinical trial that was published in the New England Journal of Medicine about a year ago. Again, it studied patients with established cardiovascular disease who are already on statin therapy, and it tested whether the addition of the Evolocumab PCSK9 inhibitor could reduce the incidence of major cardiovascular events. The study also gave us information about the long-term safety and tolerability of Evolocumab and the efficacy and safety of achieving unprecedented low levels of LDL. This slide provides a schematic of the trial design. Again, it enrolled high-risk, stable patients with coronary artery disease, cardiovascular disease. And these were patients already on high or moderate intensity statin therapy. And patients were randomized into either the placebo group or the Evolocumab group. And the primary endpoint for this study was a combined endpoint of cardiovascular death, MI, stroke, unstable angina, or coronary revascularization. A key secondary endpoint was cardiovascular death, MI, or stroke as a combined endpoint. The study also examines safety issues such as adverse effects or events of interest from Evolocumab. For example, muscle-related side effects, new onset diabetes risks, neurocognitive risks, or the development of anti-drug antibodies. And on this slide here are some of the baseline characteristics of the study patients. These were patients already on moderate intensity statin therapy or high intensity statin therapy with a median LDL level that was 92. The interquartile range was 80 to 109. So, these were patients who, didn't have super high LDL cholesterol levels to begin with. They were patients who had reasonable cholesterol levels already on statin therapy. And the addition of Evolocumab provided additional LDL lowering, where the Evolocumab patient group compared to placebo group had an additional 59% mean reduction of LDL, or an absolute reduction of 56. And in the Evolocumab group, the median LDL level went down to 30. So, the study drug patients achieved very, very low LDL levels. Again, does this actually translate into improved cardiovascular outcomes? I think that's really the important question. And this study was successful in showing an improvement in the primary combined endpoint of cardiovascular events for the Evolocumab patients. As you can see on this slide, there's a curve. The red curve represents the Evolocumab drug patients. Blue curve represents the placebo patients. The curves start diverging at about 6 months, and by 3 years, the Evolocumab patients had a lower risk of the combined cardiovascular endpoint compared to the placebo group. The hazard ratio was statistically significant at 0.85. And we saw a similar result with the key secondary endpoint, the combined endpoint of cardiovascular death, MI, or stroke. The improvement in cardiovascular outcomes was driven mainly by a reduction in MI and stroke, as you can see on the bottom portion of the slide. Wasn't driven by any difference in cardiovascular death. But certainly reducing MI and stroke has a lot of value as something that we try to achieve as physicians and cardiologists. I think one of the important findings from fourier was that lower LDL cholesterol is better. I mean, the benefit of Evolocumab was seen across all quartiles of baseline LDL cholesterol. So, whether a patient was in the upper quartile of LDL cholesterol to start with, or the lower quartile to start with, whatever LDL they started out with, there was a benefit in the Evolocumab group compared to the placebo group. There were no significant safety signals from the fourier study. No differences in terms of treatment-related discontinuation, muscle-related side effects, cataracts, et cetera. The main difference that seemed to appear was a difference in injection site reactions, with Evolocumab at 2.1% and placebo at 1.6%. So, these results are very promising. Evolocumab was able to reduce LDL by about 59% on top of statin therapy, and this effect was consistent throughout the duration of the trial. The median achieved LDL was extremely low at 30. The drug improved cardiovascular outcomes in patients already on statins, with a 15% relative risk reduction in the primary endpoint, 20% risk reduction in the secondary endpoint, and this was a consistent benefit in all patient groups. And then this drug was seen in this study to be safe and well tolerated, with similar rates of adverse events and medication discontinuation. So in patients with known cardiovascular disease, PCSK9 inhibition appears to significantly and safely decrease major cardiac events when added to statins. And this benefit was achieved by lowering LDL cholesterol well below current target levels, well below what we currently see in the vast majority of our patients. One of the main drawbacks of these new PCSK9 inhibitor drugs is that they're very expensive. And as you can see on this slide, there's a huge difference between statins and PCSK9 inhibitors in the average annual cost of therapy. And so this remains a significant barrier to more widespread use of these medications. Just very briefly, there has been a second medication that in specific situations has been shown to improve cardiac outcomes and not just lower LDL. This would be ezetimibe or Zetia added to statin therapy. The benefit was shown in this trial called Improve It. And the Improve It study looked at patients, high-risk patients after acute coronary syndrome, randomized them to either simvastatin 40 milligrams or Vytorin 10/40 milligrams. So the difference was that one group had the ezetimibe, and then looked at the primary combined endpoint of cardiovascular events over many years. And at the end of approximately 7 years, there was a 2% absolute risk reduction for the patients in the Vytorin group compared to the simvastatin group. Improve It was the first trial that demonstrated an incremental clinical benefit when adding a non-statin agent to statin therapy. It showed that non-statin lowering with ezetimibe reduced cardiovascular events and achieved even lower LDL cholesterol compared to the regular statin group. And it reaffirms what's called the LDL hypothesis that we've been talking about, that reducing LDL cholesterol prevents cardiovascular events. Finally, here on this slide are the mechanisms of actions for the drugs that I've been talking about. Statins inhibit cholesterol synthesis in the liver and result in about a 40 to 60% reduction in LDL. Ezetimibe or Zetia blocks cholesterol absorption in the intestine and results in about a 15% reduction in LDL. And the PCSK9 inhibitors block the degradation of LDL receptors and result in about a 40 to 60% reduction in LDL. All of these drugs increase the expression of LDL receptors and reduce LDL cholesterol levels. And we now know that to a greater or lesser extent, these medications can also help to reduce cardiac events. So here are the take-home points that I want you to come away with from my talk. LDL lowering reduces cardiovascular events. Improved outcomes continue to be observed even down to very low LDL levels. Statins remain the first choice drug for lipid lowering in patients at risk for cardiovascular events because of their efficacy and safety and cost. But new PCSK9 inhibitors do offer an additional option for LDL lowering, especially for the familial hyperlipidemia patient or statin intolerant patient. In high-risk coronary artery disease patients, adding a PCSK9 inhibitor to statin therapy can further reduce cardiac events. Thank you so much for your attention.
We'll take a couple of minutes for questions for Dr. Huang, if you like, before
Yes.
Dr. Kaiser gives his lecture.
Yes.
Of that with your patient population. You tell them they got to be vegetarian, or you're going to slam them with all these costs and medications, or I mean, how do you approach the problem of our culture?
Well, yeah, I mean, that's a very good question. If I heard it correctly, your question is about how you approach the patient given all the complexities, including, the burden of drug therapy and dietary factors that influence cholesterol. Is that correct? Or?
Well, do you tell them all to become vegetarians? Do you start there?
So, I mean, I think that, whatever the individual patient's situation, there's always going to be a role for therapeutic lifestyle changes that include dietary improvements. I don't think medications are a replacement for a heart-healthy diet and a healthy lifestyle. Certainly, everything that I've been talking about is stuff that should be added on top of therapeutic lifestyle changes that should be made by the patient to reduce cardiac risk. I think that certainly in the patient who does everything reasonably possible to improve his or her diet and is still at high cholesterol levels, we know that there is this genetic disposition to high cholesterol, and it's one that can be addressed with pharmacotherapy. I think that in my patients who I see in the office who are resistant to taking cholesterol-lowering medications, I try to explain to them that yes, there are dietary factors that are involved in cholesterol and that you should be doing what you can there. But there's also this genetic factor behind their high cholesterol levels that may not necessarily be fully addressed by diet and lifestyle changes. And that because we have new medications and technology that can improve their cholesterol and improve their cardiac risk, why not take advantage of these treatments that can allow them to live healthier, better lives? So I hope that answers some of your question. Yes?
If you take the risk calculator and put numbers in, it turns out that every single man over the age of 63 with even no risk factors has a more than 7.5% 10-year risk, and every woman roughly over the age of 70. So the question would be, why bother even testing? Should we put every man over the age of 63 and every woman over the age of 70 on a statin?
Well, that's certainly something that has been advocated by some people. It's a difficult issue to address. I mean, I think that certainly in our society, in our culture, we don't necessarily have the healthiest diet or lifestyle. Our cholesterol levels are higher in general than what they ideally should be. I think that all of our patients, or the vast majority of our patients, should certainly be paying more attention to their diet and lifestyle and trying to live a healthier life. I would say that the risk calculator indirectly points towards the need for more attention on a population level to healthier diet and lifestyle.
Yeah, hi. Well, thank you. Just basically two simple questions. First, the statin question, with the primary prevention trial showing that if somebody has low cardiovascular risk profile, the statins really don't make much difference in the long run as far as reducing cardiac events and death. And the second one has to do with these new PCSK9 inhibitors that basically promote, the salvation of these LDL receptors. And the studies are very interesting. Probably would work more on patients that are at higher risk, because even in these data that you presented, it doesn't show that there's any change in cardiac mortality, statistically significantly change. Can you please comment on that?
So in terms of the second part of your question about whether PCSK9 inhibitors can be used as lipid-lowering therapy in primary prevention situations, certainly they've been shown to lower LDL. They haven't been studied for cardiovascular outcomes in the primary prevention situations. So yes, even though we might infer that they would be similar to statins in improving cardiovascular outcomes in primary prevention, we don't necessarily have that data because so far the data has been on the high-risk secondary prevention patients. And then in terms of the first part of your question, yes, I would agree that for the low-risk patient, there isn't really necessarily a need for statin therapy, especially since, in the real world, taking a medication does represent a burden for the patient. It is something that can cause side effects, can interact with other medicines patients may be taking. These are all some of the real-world issues that we all deal with as practicing clinicians.
Last question, and then we'll proceed with our next topic.
Okay, so with new technologies, LDL is historically, the ideal LDL has historically gone down, down, down. So where is it now, in your opinion? What is an absolutely ideal LDL level?
So, that's a great question because, I don't think that we really know what is an ideal LDL level. I do feel that patients are going to be healthier in the long run if they have an LDL level that's less than 100. I mean, certainly we currently try to lower LDL levels to less than 70 in our CAD or CAD risk equivalent patients, at least in my practice. But I don't think that there's necessarily a clear-cut answer to your question.